So before we begin with our presenters, to introduce this topic, I would make note that it was just 2 years ago, on January 26, 2020, the CDC confirmed the very first case of COVID in California. And on February 6, 2020, a person from San Jose became the first COVID death in the United States due to myocarditis from the novel coronavirus infection. And in a little over 2 years, the CDC has reported, as of yesterday, 79,165,308 COVID cases in the United States and 957,752 confirmed deaths from COVID-19. And this includes over 1,000 children. There have been over 1 million excess deaths in the US during the pandemic. Now, given the horrifying numbers of pandemic deaths, much of the focus on addressing the pandemic has been on decreasing the death toll due to the coronavirus or due to overwhelmed hospitals and intensive care units. However, death and hospitalizations are not the only serious consequence of COVID. COVID-19 infection can lead to high rates of persistent disability, sometimes referred to as long COVID. Recently in the United Kingdom, the Office of National Statistics showed that there was a rapid rise in long-term illness in people aged 16 to 64 over the last 2 years, with more than a third of working-age people in the United Kingdom suffering from long-term illness. Studies of long COVID indicate that over a quarter of people infected with COVID develop one or more persistent symptoms lasting months, sometimes even greater than 6 months after infection, including people who were initially asymptomatic and only had mild acute symptoms. So in addition to death, what is the research revealing about the long-term consequences of being infected with this coronavirus? Many patients report new or ongoing neurological symptoms after COVID infection, including changes in smell or taste, brain fog, including reduced attention and memory, fatigue, headache, muscle pain, sleep problems, dizziness, and mood changes. A recent Oxford study of brain scans taken before and after COVID infection found brain shrinkage and cognitive function deficits. COVID-19 infection has also been linked with new psychotic episodes in patients. In addition to the severe acute lung damage requiring prolonged ventilation, intensive care, ECMO, or even double lung transplant, the ones we hear about, COVID-19 can also cause long-term lung damage resulting in persistent shortness of breath. A study of Veteran Affairs data showed that COVID infection is associated with an increase in 20 cardiovascular problems over a year after initial infection, even in patients with mild disease or who are at low risk of cardiovascular disease. The risk of heart failure increased by 72%, heart attacks by 63%, myocarditis by 538%, and stroke by 52%. COVID may also trigger ongoing autoimmune response or chronic inflammation. In fact, over 7,500 children have developed a serious condition called multisystem inflammatory syndrome in children, sometimes known as MISC, and 63 children who've gotten MISC have died. In fact, the majority of MISC patients are Latino or Black. MISC is a condition following COVID infection where different parts of the body become inflamed, including the heart, lungs, kidneys, brain, skin, eyes, and gut. Now, diabetes is a risk factor for COVID-19, and COVID infection has been associated with worsening diabetes symptoms. However, children who have been infected with COVID have also been observed to be more than twice as likely to be diagnosed with diabetes. Pregnant women are higher risk for severe disease from COVID-19, and COVID infection in pregnant women is associated with a 3-fold increase in stillbirth, as well as a 5-time risk of death for the woman herself. In addition, COVID-19 infection in pregnant women is associated with increased rates of very preterm birth with resulting increased risk of infant complications. Now, there's been a myth that COVID vaccine may be associated with infertility, which is untrue. The COVID vaccine does not cause infertility. However, the coronavirus itself infects the testes and penis. And COVID infection in men is associated with lower sperm counts and a 6-fold increase in erectile dysfunction. And these are only some of the post-COVID problems that have been reported. Long-term disability from COVID-19 carries significant financial costs to the state and society, as well as, of course, personal suffering of patients and challenges for parents and caregivers. Consequences include increased healthcare costs, reduction or loss of employment, increased costs for workers' compensation and disability support programs, and greater demand for special education services. It is estimated that as much as 30% of COVID health burden could arise from COVID-induced disability. Now, COVID-19 has only been with us for a little over 2 years, so definitive data on the long-term effects of COVID infection is still limited. But what scientists have already learned indicates that the long-term burden of COVID infection is likely to be very large for both families and society as a whole, affecting millions of Californians. Thus, we should take every effort to prevent people, especially our children, from ever being infected or reinfected by this very serious disease. So in this hearing, I'm very pleased to bring together experts to share what we know and what we still have to learn about the long-term effects of COVID infection and long COVID. And with that, I would now like to give the opportunity for the chair of our Pandemic Response Committee, Senator Newman, to make some opening remarks as well. Senator Newman.
Thank you, Senator Pan, and thank you in advance to all of the participants in today's information hearing on long COVID. For the past 14 months, I've had the privilege of serving as the chair of the Senate Special Committee on Pandemic Emergency Response. In that capacity, I've been grateful for the participation and support of Senator Pan and other colleagues as we have grappled with a wide variety of pandemic-related issues as they have arisen. Over the course of the first 2 years of this unprecedented public health emergency, the overall focus of public health policies has understandably been geared toward containing the pandemic and addressing its profound and frequently tragic impacts. Now, as the state continues to shift to this next phase of pandemic management, post-Omicron, it's imperative that we now start to give rigorous attention to understanding and treating long COVID in the months and years to come. As we will hear today, the scientific community's knowledge of long COVID is definitely better today than it was a year ago, but there's so much more that needs to be done, especially in the area of treatment. Much is still being discovered about the SARS-CoV-2 virus, as Senator Pan has noted, but we do know now that the virus's reach can be throughout the body, and its impacts can be both devastating and chronic. For many people dealing with long COVID, their symptoms can be diffuse and puzzling, making it even more challenging for them to get the care they need. Often these patients had nothing physically wrong with them before they contracted COVID, so living with long COVID is life-altering. Some of these patients are with us today to talk about the challenges they face day to day. Their stories matter. As daily case and death rates continue to improve, I urge all of us to be as attentive as possible to the kinds of risks and barriers these patients find themselves facing. There are no easy solutions or answers to long COVID, as you'll hear today, but we do know that the impacts will be felt across multiple systems and have substantial implications for policies and for people. After today's hearing, we hope to have a better sense of how California can engage with our multiple stakeholders to ensure that these patients are not left further behind to fend for themselves as we enter this next phase of the pandemic. Thank you again to all of the panelists for your time and efforts. Thank you, Mr. Chair, for this time to comment, and I look forward to today's conversation.
Thank you, Senator Newman. Do any of the other members who are present wish to make any opening remarks? Okay. Seeing none, then we'll go ahead and begin with our first panel on the overview of long COVID, and pleased to welcome Dr. Stephen Deeks, Principal Investigator, Long-Term Impact of Infection with Novel Coronavirus Study at the University of California, San Francisco, and Dr. Sindhu Mohandas, Pediatric Infectious Disease Specialist at Children's Hospital of Los Angeles. Welcome, and please, I guess we'll start with Dr. Deeks. Please begin your presentation, and then we'll allow questions from members after each panel. So Dr. Deeks.
Thank you, Chairman Pound. So I'm going to show just 3 slides here as I walk through some of the big picture overview of what's been happening over the last 2 years. And I think the story about how we got here is important, and Senator Pan discussed this in some detail as well. But we're now 2 years into this pandemic, and the focus is clearly now shifting from the management of the acute syndrome to these sort of now chronic lingering consequences of the original infection. But if you go back in time, this story I think is informative. What actually happened is that the first cases occurred in March and April and so forth, about 2 years ago. And there was this immediate focus on dealing with people in the hospital for obvious reasons. At that time, we and a number of other groups were aware that these types of infections might actually result in long-term consequences. We've seen this with other viral infections. We've seen it with bacterial infections like Lyme disease. We never quite fully understood what had happened in the past, but we had a vague sense back in the day that something might happen. So we put together a cohort where we began to enroll people who had basically survived the acute setting and just started to follow them forward in time. And now we're 2 years into this, and I'll mention a little bit about what we learned. But what happened next after this was in the first few months on social media, these reports just exploded. And then these advocacy groups, a few of whom you're going to hear from today, formed, I believe, in the spring and the summer of 2020. And these groups have been extremely effective in getting the word out through the national media and also through various different stakeholders, particularly governments. The UK government has invested massively. And now, as of about a year ago, the US government is now investing about $1 billion into the study of this problem, long COVID, and its management. And that's the Recovery Initiative, which I can go into some detail. So that's how we got here. So what do we know? We don't really know that much. Importantly, we know that this is real. Okay. In the first year or so, there was a lot of pushback from the medical community, whether this was actually real, that a lot of people assumed, that there's a lot of anxiety, a lot of stress, a lot of issues going on in the background due to the pandemic, and that everybody's health was being affected. And that what people were complaining about was not due to the virus, but due to the pandemic. I don't think anyone believes that anymore. People now have their own personal experiences. Clearly, the medical data are now becoming very strong. A subset of people, and the frequency is all over the map. I think it's probably in the 10 to 20% range, depending on how you define it. But anyway, a subset of adults who acquire this infection will meet a standard definition now of long COVID. And what is that definition? Well, the WHO basically says that these symptoms have to persist or evolve within the first 3 months, last for a couple months, have no other explanation, not have been present before the SARS-CoV, and having some impact on people's day-to-day living. And that's vague, but it's basically, I think, a fair assessment of where we are. And SARS-CoV-2 spreads throughout the body. And so it's perhaps not too surprising now that some of the lingering effects that we're dealing with are quite systemic. And there are different, all the people studying this are beginning to realize that there's these different clusters. There's different flavors, right? People have a neurologic version of this with the brain fog and neuropathy and so forth. Others have a syndrome that's kind of similar to chronic fatigue syndrome with disabling fatigue and post-exertional malaise and so forth. There's a strong, distinct cardiovascular flavor of this in which people have heart rate problems and blood pressure problems and develop acute cardiac complications, as Senator Tandon mentioned. And there's a unique syndrome called POTS that's actually was probably one of the easier ones to diagnose. Again, it's an issue that has to do with the heart rate. And to be honest, these are different flavors, but there's a fair amount of overlap. But the key thing about these syndromes is that they're really hard to diagnose. People feel them, and people can come in the clinic and describe what's happening, but there's no x-rays, there's no blood tests, there's no way to objectively prove what's going on. And that's a big challenge for clinicians and patients for lots of reasons, and including trying to get people to qualify for disability and so forth. So here are the questions, right? And no answers. How are we going to define this? We don't have a definitive way to diagnose the syndrome. If we can't define it, we can't measure it, we really can't study it. This is a big deal. Who's at risk? Almost all the studies have basically shown that the more sick you are during the acute infection, the more likely you are to have long COVID. But clearly people who are minimally symptomatic are at risk of developing long COVID, just at a low risk. Women seem to get it more than men, and people with various different comorbidities, including diabetes, are also at higher risk. What is the natural history? It's all over the place. Many people, in my experience, tend to slowly get better over time, but certainly there's a group of people whose symptoms persist and have so now for 2 years. Other people wax and wane, not that well characterized. Will vaccines prevent long COVID? That appears to be likely to be true. All the cohort studies that have been reported to date suggest about that people who've been vaccinated become infected, can get long COVID, but the rates are about 50% lower. Will antiviral therapies during the acute infection prevent long COVID? We have no idea. I suspect that this will be true, but we really don't have any data. A big question is Omicron, right? Since the numbers of people who've gotten Omicron is so massive, we're all really worried about this. And at this point in time, we just have no real data to say whether or not people who have the Omicron version are going to get long COVID. There are definitely reasons to be optimistic that it's not going to actually be as strongly associated. But again, we just don't know. What is the mechanism? That's actually our area of expertise. There are 4 or 5 different pathways at play. It's certainly probably going to be multiple factors. And finally, how should this be managed? There is a growing therapeutic research agenda, small studies that are emerging. But right now, most of the management is rehabilitation, physical therapy, mental health support, financial support, and so forth. It's my personal opinion that what people who are dealing with long COVID now need most is a clinic where they can go to get a holistic approach, get access to information, get access to clinical trials, get access to therapy, get access to help with the various different economic issues, and these clinics are popping up, but I'm hopeful that we'll have these centers of excellence that emerge over time that will help address this issue because it's sorely needed. So I'm going to stop there and turn it back to you, Senator Tim.
Okay, thank you so very much, Dr. Deeks. And we'll now move on to Dr. Mohandas from Children's Hospital Los Angeles. Welcome.
Good afternoon, members of the committee. I'm Dr. Sindhu Mohandas. I'm one of the pediatric infectious disease physicians at Children's Hospital Los Angeles. I'm also a CHLIP principal investigator on the RECOVER study that Dr. Deeks mentioned. So thank you so much for giving me the opportunity to discuss this important topic today. Throughout the pandemic, I have been actively involved in caring for patients, formulating evidence-based guidelines, and participating in multidisciplinary teams to care for patients with COVID-19 and its sequelae. Since the start of the pandemic at CHLA, we have seen over 1,000 children with COVID-19, and of these, nearly 200 have needed intensive care unit care. And in April 2020, children started presenting with a new syndrome called multisystem inflammatory syndrome in children, or MISC. MISC is a rare hyperimmune response to the SARS-CoV-2 infection that occurs several weeks after acute viral exposure or infection. Children can present with an acute febrile illness, cardiac issues, which can include severe cardiac dysfunction, as well as coronary abnormalities, and shock. MIS-C can be serious and even deadly, but fortunately, most children who were diagnosed with this condition have gotten better with medical care. As of March 1st, the CDC has reported 7,459 cases in the United States, with 63 deaths. Our team at CHLA has cared for 186 patients so far with MISC, and this accounts for more than 60% of patients in the Los Angeles County and 2.5% of the MISC patients seen nationally. 65 of our patients have needed ICU care, and unfortunately, we have had 2 deaths. We have also seen that MISC affects minority communities disproportionately. More than 52% of our patients have been Latinos, and this probably reflects the fact that these patients are also disproportionately affected by COVID-19 overall. Though most children recover from MISC, the long-term consequences are unknown. We continue to follow these children closely in our MISC clinic. As we were working at our MISC clinic, we started getting more and more contacts from patients, PMDs, about a new syndrome in children, which really did not fit into the MISC category. These children had lingering symptoms long after the COVID-19 infection, even if the initial infection was with mild symptoms or no symptoms at all. This is, as you heard Dr. Deeks say, variously referred to as long COVID, long haul COVID, or scientifically as post-acute sequelae of COVID-19 or PASC. Symptoms of long COVID are very diverse, and we learn of new symptomatology every day. More commonly seen symptoms in children in our clinic have been severe fatigue, headaches, shortness of breath, chest pain or palpitations, difficulty concentrating, which is also called brain fog, muscle pain, and changes in smell or taste. Many of these children were previously completely healthy and doing very well in school. And after developing these symptoms, they are unable to participate in school activities or sports. Various studies have shown that the prevalence of long COVID in children is between 5 and 50%. However, we still have a lot to learn about long COVID in children, and larger longitudinal studies are required to understand the true prevalence. And I'm hoping Recover will be able to achieve this in understanding the true prevalence of disease. I helped establish the Long COVID Recovery Care Clinic at CHLA, and this is one of the very few clinics in the country that offers long COVID care for patients. We have had several patients and parents present to our clinic in tears, frustrated in their search for medical care for their children. Care of these patients is complex and challenging and needs close coordination between a multidisciplinary team, which our institution so far has included infectious diseases, cardiology, neurology, pulmonology and sleep medicine, behavioral health, rehab, and social work. The goal of therapy is to help patients transition back to daily activities as recovery progresses. And this is very individual and can take weeks in some patients, but months in others. So even though we are at a stage when we may be moving past the pandemic, with regards to long COVID, I believe that we have only seen the tip of the iceberg. Symptoms of long COVID are keeping children out of school and their parents out of work, and have potential for significant public health impact. We need to continue to invest in infrastructure and resources, both for clinical care and continued research efforts, to understand the prevalence of disease, mechanisms of disease, so that we can devise optimal treatments and prevention techniques. Thank you very much.
Thank you. Thank you to both of our presenters. Questions from committee members? Okay, well, I have a few questions, and again, really appreciate the presentation. So I guess, Dr. Deeks, you talked about the importance of, and actually we've just heard also from Dr. Mohandas about the importance of, I guess, centers of excellence, right? I mean, this is you told is a complex disease. In fact, I think you even mentioned we don't really have a definition of long COVID because there's a lot of variation and so forth. Maybe you can speak to that first. So where are we on the path to actually better defining this disease? And obviously, in order to collect epidemiological data and so forth, we do need definitions, right? I think you were involved with when HIV first came out and so forth. Can you speak to what are sort of the things we need to do? One, to be able to do better defined research on what long COVID is, so in terms of definitions. And then the second, and then maybe also have Dr. Mohandas follow up on this, in terms of the setting up that infrastructure of these centers of excellence, which to both collect data, but also provide the complex care. I mean, there's so many specialists involved and so forth that's not available. I mean, even here in Sacramento, here where we're having the hearing, I mean, I used to work at UC Davis Children's Hospital. There's a limited number of subspecialists that are available. The pediatric subspecialists are already pretty taxed with diseases before, and then we can talk about other specialists for adults and so forth prior to COVID, and now we have the issue of long COVID. But maybe Dr. Deeks, you want to start off by talking about where we are in terms of actually defining that research, getting the definitions, and then moving toward actually getting people access to high-quality care in the face of the uncertainty related to this disease?
So those are two very big questions, probably the two most important questions, and they're actually linked. So the first question really is how we can define this. And again, I don't really actually have a good answer to that. Right now, we're doing these deep dives, these perspectives, cohorts, the Recover Initiative, for example, and the hope is that we can actually, with multiple different imaging, multiple different procedures, asking millions of different questions, we'll come up with something that is crisp and clear that will define what this is. I'm a little bit skeptical that we'll do that. I think at the end of the day, we're going to basically have to count on quantifying how people feel. Now that's doable, but the issue that we're going to confront here again is that, well, it's hard to use that information to say someone qualified for disability. You know, Social Security Administration always wants some hard facts. Exactly why are they disabled? In fact, actually, I'm part of a meeting that's happening in Washington next week, 2-day meeting, where the Social Security Administration is trying to figure out how they're going to define this clinically. Another big issue about the definition is that unless we have a precise way to measure long COVID, it's really hard to get industry to engage to develop therapies, right? I knock on the doors of all the drug companies saying, you guys have got to get involved. There's all these things we can be doing. And they say, okay, fine, we're committed, but what's the end point? How are we going to basically prove to the FDA that our drug works? And that's not easy to do when you have these vague types of symptoms. Anyway, so that's where we are right now. And until we have a precise way to define this, it's really going to be hard to develop the treatments. Which takes me to the next question, which is the issue of how we're going to care for people now. So as you mentioned, I was an HIV doc back in the 90s, in which we had a similar situation, right? We had, you know, 1 million people in the United States who were suffering from HIV. They were in these primary care clinics. They didn't have access to good care, didn't have access to expertise. The infection was affecting all parts of their life, including their ability to work, stigma, mental health, substance abuse. All of these issues were sort of intertwined into a disease that was more medical, was also kind of social, economic issues. And our ability to care for people with HIV, many of whom were marginalized from different underrepresented communities, our ability to care for these individuals dramatically improved when we developed these centers of excellence, many of them funded by the government, including the Ryan White Initiative. And I do think that if we had the ability to do that now, put together these centers of excellence that can deal with all aspects of this issue and that will allow everybody to attend, including those who have insurance, that would be a great step forward.
Okay. Thank you. And Dr. Mohandas, do you want to address this issue as well?
Yes, I agree. The challenge really lies in how do you exactly define long COVID. And the challenge also is that the CDC and the World Health Organization define it differently. But we do need a definition to work with these patients and to be able to give this diagnosis to patients. So as a working diagnosis for our clinic, we use it to say that any child who has had new recurring or ongoing symptoms 4 weeks after the first COVID infection. If they were to meet this criteria, and the other criteria we use is that these symptoms significantly affect the quality of life, and these symptoms were not present prior to the COVID infection. When children meet this criteria, we then see them in our long COVID clinic. And the other question about centers of excellence, I couldn't agree more. Since we have started this, and just as you mentioned, pediatric specialists are overstretched. It is really difficult to have a whole set of specialists being able to contribute to this care without a significant investment in this process. So I think a better infrastructure, better funding into developing this as centers of excellence will be a great benefit to the patients.
Okay. Thank you. Senator Rubio.
Thank you, Mr. Chair. I really appreciate the information that is being presented today, but I have a question in particular as it pertains to education. I know that we were talking about the physical side effects for children, and I'm just wondering if there's plans to partner with educational institutions to gather data. One of the often words used here is brain fog, not only in adults, but in children as well. And I'm hearing anecdotal data from educational institutions. So I'm just wondering if there's a plan in place so we can ensure that we are actually in real time gathering the information from teachers and institutions. I don't think we can find a solution unless we have that information. So I want to turn it over to you to see what you can share.
Dr. Mohandas, it sounds like it might fall in your bailiwick.
Yes, I couldn't agree more. I think it's a really important question. We don't have anything in place right now, but that's something that should definitely be explored. We have had parents in clinic, and as we said before, these children externally look well. There is nothing to say that they suffer from this chronic condition. So having this partnership with educational institutions, increasing awareness so that educational institutions are aware and can make the necessary changes that these children require will be a great help. And this is something that I would be very happy to participate in making happen.
Thank you. Other questions? So actually, Dr. Dietz and actually Dr. Menendez, I know that one of the questions out there, and again, it's sort of related to the fact that we don't have a definition, or definition isn't consistent. But I did say in my opening remarks, because different researchers in different parts of the world have found different frequencies of long COVID, and I guess without a definition, it's hard to say what percentage it actually is. But can you maybe shed some light as to how big of a problem is this when you think about the fact that you're talking about people having these long-term symptoms, needing these social supports and so forth, and certainly as legislators, we want to be sure that the state is preparing, is going to be providing services, and in fact, our next panel, we're going to be hearing from patients and advocates about that. From your perspective, what are some of the things we as a state should be anticipating, given what you're seeing and the frequency and how often and how many patients are being affected in terms of preparing to serve these patients and these families? How many people are we talking about? We have a population of 40 million in this state. Obviously, some of it depends on how much if there's a future variant, how much we continue to let it spread. We just got off Omicron. We've been through so many different waves. So I realize it may be a little bit, there may be some guesswork involved, but you're probably the closest things we got to experts who can maybe at least give us at least a ballpark range of what we should be thinking about the burden of long COVID that the state would need to address.
Okay, I'll give you my opinion.
Okay, yes, it's opinion.
My opinion, based on the data, which is all over the place, and also based on what we're seeing in our cohort. So I think it depends on the wave, right? So the first 2 or 3 waves is where I think the greatest burden of disabling disease occurred. People weren't vaccinated then, we didn't have treatment, we weren't masking, there were high virus exposures. Some of the sickest people that we're dealing with in our cohorts now are from the first wave, and maybe from the second wave. When Delta came around, a lot of people were acquiring Delta when they were vaccinated. And I'm pretty sure they're at risk of developing long COVID, no question, but the rates are much lower. And I have no idea what's going to happen with Omicron, and it's the big unknown. Again, my guess is that we're not going to see a lot of disease Omicron, but again, we do not know. So I would say if you have 40 million people in the state of California, 10 million people become infected, I would probably say a couple million are definitely going to have persistent symptoms, but disabling disease that persists for more than a year, that's, I think, is where a lot of the attention is in terms of the media and what we're doing in the clinics and disability and so forth. That's probably going to end up being a few percent, I'm guessing. So we're talking, I'll get my math right, several hundred thousand people, a few 100,000 people, at least in the state of California, could end up with profound residual disease that's having a big impact on their day-to-day life.
All right, thank you. Dr. Mohandas, did you want to take a shot at that question?
Yeah.
That was adults. I know nothing about children.
There you go.
Yeah, with children, it gets a little more complicated. That I mean, the adult knowledge about long COVID, it has been longer. We are only just starting to explore this diagnosis in pediatrics. So I would say the information in pediatrics is even more lacking than that in adults. But what I can tell you is, like just as Dr. Deek said, we are now seeing patients who are having long COVID as a consequence of the first wave or early Delta. So there is a lot more we will see in the next few months. And just since this clinic opened, which was probably the last 4 months, we have already seen 45 patients in our clinic. And we have calls from all over the country, patients and parents wanting to be seen in our clinic. So there is really a huge need. And in terms of percentages, because these studies have looked at symptoms at different time durations from the initial infection, that's why they're all over the place. So we really need some kind of a longitudinal study to understand that better. But if I were to guess, I would put the number somewhere between 10 to 20% of those who get infected have long COVID.
No, I appreciate that. I would also, and maybe you can just sort of follow up to that, Dr. Mohandas. You know, we've actually seen increased rates of COVID infection in children with, I think, Delta and Omicron, right? So for whatever reason, more in children now, and the vaccination rates for school-age children is still fairly low. I think we're like the 30% or something, 20-30%. So we still have a ways to go there. And then we can't vaccinate children under 5. And I don't know whether you can touch on what about really young children, whether that, you know, what you're seeing there. And then maybe just for your last concluding part of your response, you know, so many people have said, well, COVID's not serious. It's like the flu or the cold. You're an infectious disease specialist. You're seeing these patients. Maybe you can finally end your remarks with what's your opinion of people who say that?
Yeah, so long COVID patients that we have seen, almost more than 90% had very mild or asymptomatic illness. Mm-hmm. So that's why I kind of hesitate to say that most likely Omicron will not result in a lot of long COVID, because really the big subset of patients that we're seeing in our clinic really had very mild illness. And just as you mentioned, many more children got infected during the Omicron wave, and it's to be seen. So I would hesitate in saying that we will not expect more severe long COVID with Omicron. I think it's something that we have to wait and see. So mild infection does not mean that you cannot have sequelae. Both our patients with MIS-C and patients with long COVID had mostly very mild infection, and in many cases weren't even aware that they had infection. It was only on questioning they could remember a household exposure. So mild infection is not equivalent to not having problems down the line. So and parents should be very aware of this. So vaccination, there is this discussion that vaccination may not be that useful in children since the illness is mild. But I would encourage everyone to think beyond the acute infection, these sequelae, which can be really life-threatening and severe and life-changing for children.
So is COVID the same as the flu or a cold?
Not at all. I think over the last 2 years, we have seen more than enough evidence of that. We need to be really careful and protect our children in every way that we can.
All right. Thank you. Thanks so much, Dr. Mohandas. Thank you, Dr. Deeks. Is there any other questions from the committee members? Okay. Thank you so very much for your presentations. Next, we're going to move on to our second panel, which on living with long COVID, the patient-family perspective, and we're going to be hearing from Lauren Gruters, patient, and her mother, Stacy Gruters, followed by Angela Vasquez, who's patient and president of Body Politics, and then wrapping up this panel, Jennifer Stark, patient and managing attorney with Disability Rights California. So let's begin with Lauren Gruters and Stacy Gruters. Welcome.
Hi there. Thank you so much. I apologize, Lauren won't be joining us today due to long COVID, actually, ironically. So my name is Stacy Groders. It's an honor for me to be here today. This is a club that my daughter and myself never wanted to be a member of. I'm very interested to hear everything you're saying. It is emotional for me to hear because getting care for our daughter has been nothing short of challenging. I just appreciate the opportunity to share. Just for context, I'm an assistant principal of a K-8 school in the Irvine Unified School District. I've been in education for 28 years, so I'm, very aware of the challenges with school and COVID as well. We have 3 children, my son and then twin daughters. My son is 22, my daughters are both 20. In August of 2020, after being home and quarantining in California very carefully, we sent them back to the University of Alabama, where they attend college. And within 2 weeks of being back on campus, both of our daughters tested positive for COVID before the vaccinations were available. They were sick with a fever for about a day, lost their sense of taste and smell, and then within 5 days, we're back totally normal. We kind of felt lucky, like they had weathered it easily, and we felt very fortunate that, it wasn't going to have any long-term effects for them. Just so you know, prior to Lauren having COVID-19, she had never experienced any psychiatric episodes of depression or anxiety. She is attending college on a full academic scholarship. She's extremely social, bright, warm, engaging. At college, she's in a sorority, has been in leadership positions, no underlying health conditions, physically active, an athlete, very fit. And then about 6 weeks later, after her first COVID positive test, came this sudden onset of extreme anxiety that was crippling. Her twin sister called us very concerned about her, took her to student health. They treated her like she was like a college kid, basically having like a psychosis or a mental breakdown. Within a couple of days, she was almost catatonic. She was having a hard time speaking, couldn't answer basic questions, couldn't organize her thoughts. So I jumped on a plane, got out there, and took her to a new doctor. And she basically suggested that because we live in LA and they had more experience with COVID, that we should probably get her home. So we got her on a plane, brought her back, went right to the emergency room at Mission Hospital in Orange County. And again, was treated like we had a college kid who was having a mental health breakdown or was pregnant or had done drugs. So they did a drug panel. Those were the only tests that were done, like screening her for drugs, making sure she wasn't pregnant. It was very humiliating for her, very traumatic experience. And then due to COVID, my husband wasn't allowed to be in there with us. We had to beg for them to let me be there because it was still early days of COVID. Thank God we have a wonderful pediatrician who we've known since she was 4 years old, Dr. Ball, who followed up with us that was on a Sunday, on Monday morning, and he had her admitted to Children's Hospital of Orange County. She ended up spending 8 days there. They did a whole battery of tests and quickly realized that she had encephalopathy, that her brain had actually swollen. So a lot of what you're referring to here. It was very new. They were kind of even unsure, except that every single test that they ran had was negative, which is awesome. She had no underlying conditions. However, COVID was still positive almost 7 weeks later. So we were very fortunate that in the hospital, they had given her some medication for anxiety, like a fast-acting one, and it almost triggered her to come out of this catatonic state. And within 30 minutes of being on that medication, she was able to explain to us how she was feeling, how she felt like she was behind a glass wall, how she couldn't communicate, and she was back to herself. So we got her a lot of care, and after several different doctors, neurologists, psychiatrists, therapy, we sent her to school, and she was doing well. She finally had a normal semester this past fall. She had been healing up and doing great, back to her kind of lively, energetic self. Fully vaccinated, boosted, and then on January 2nd of 2022, she tested positive again. I guess I should go back and also say that in August we were concerned to kind of get a baseline for what was happening cognitively for her. So we paid for a neurological educational assessment. And our only baseline was that Lauren had been identified as gifted when she was young. So we knew that her IQ was showing like in the 98th percentile as an adult, which also matched her as a child. What we didn't have a baseline for was her executive functioning, but her test results came back that she was her working memory was in the 18th percentile. And I promise you that is not how she was ever growing up or in school. And so I think that was a big cause of the anxiety. She had this, her cognitive ability versus what she was able to do was completely different. So she had to relearn how to learn, which is not easy at 20. The good news is her brain is still young and she has a couple more years to heal. But this January 2nd, she actually tested positive for a second time, even though she's boosted. Again, she was fairly sick. We wouldn't have ever tested her except she was a close contact for someone else. And we thought she was okay again. And then Friday, this past week, she had another episode of shutting down, and we had to fly her home from school again a week before spring break, get her back, seeing her doctors here, getting her back on medication. And she is doing better, but we're still dealing with this. And it's just in the price of long COVID is extraordinary, emotionally, socially, physically, financially. My husband and I have become acutely aware of our privilege. And we have many. We have an enormous loving network, family, friends. We're highly educated. We're healthy. We have financial privilege too, that we're able to hop on planes, bring our kids home, get them the best medical treatment, pay for therapy, yoga, every cognitive behavior therapy. I mean, we are trying everything to help our kid get her life back. And it's hard because she is over 18, and she falls in this very unusual category of not quite being an adult, and not quite being a kid. And we have struggled to get her help that is meaningful, and it is also very challenging to explain to people that this is actually real, I mean, you know, we live in California, but having the experience in Alabama, she has to have two sets of doctors, right? She has to have doctors where she's living there, and they just aren't even informed on this at all. So the fact that you are all having this conversation and that you're talking about centers of excellence, and I mean, it makes me very hopeful for the families that are living with this, because it's a nightmare. And so her official diagnosis now has been post-COVID neurological syndrome. But I mean, even her psychiatrist in Alabama was like, well, maybe she just, you know, it prompted, you know, underlying psychological conditions that would have been there. But her doctors here are saying, no, this is COVID. Her brain changed due to COVID. And we can see it in those educational assessments that were done. So yeah, that's our story.
Well, thank you, Ms. Gruters, for sharing this story and sharing with all of us in the public. I know, well, I shouldn't say I know. I know. Thank you for your courage in sharing this. It's not always easy, and again, really appreciate you sharing this with all of us. Let's now move on to Angela Vasquez, President Body Politic.
Great, thank you so much. My name is Angela Mediquez Vasquez, and today I'm here to speak as a disabled former athlete, long COVID patient, and president of Body Politic, the grassroots patient-led organization at the forefront of long COVID advocacy, fueled by our support group of over 10,000 patients worldwide. Thank you, members of the committee and staff, for inviting me today. Before getting COVID-19 here in Los Angeles in March 2020, I was a runner for nearly 2 decades. In fact, the morning of the day I first started feeling sick, I had gone for a great 3-mile run. It's been nearly 2 years of COVID-19 symptoms, and I have not run since. I'm not sure when I'll be able to. I experienced an increasingly scary set of symptoms, including severe levels of blood clots, a series of mini strokes, brain swelling, seizures, painful heart palpitations, severe shortness of breath, extreme confusion, and numbness in my face, hands, and legs that progressed to an inability to walk for several days, and at moments unable to speak. I also developed new onset anaphylaxis after every meal. And just hearing Stephanie describe her daughter's experiences, they were directly similar to my own experiences, and inability to really get competent, compassionate care, especially at the beginning of the pandemic, from any of the major hospitals in Los Angeles. It was quite a terrifying time, and I survived all of those symptoms, including the mini strokes, from my bed. Um, with long COVID, I now have several ongoing chronic conditions, including likely a mild form of myalgic encephalomyelitis, ME, also known as chronic fatigue syndrome or ME/CFS. It's a neuroimmune condition whose hallmark symptom is post exertional symptom exacerbation, which means when I push myself past a dynamic threshold, I will experience a relapse of my worst symptoms like insomnia, brain fog, and confusion, sleep apnea, heart palpitations, fevers, and severe migraines. I have developed a strict pacing regimen that allows me to work from home more than full time, really. But I don't do much else. I don't socialize, I don't enjoy my old hobbies, and I don't even leave my home, especially now that I'm considered high risk for complications for a subsequent breakthrough infection, as you just heard. Um, Unlike me, at least half to nearly two-thirds of surveyed long COVID patients could not work full time. The vast majority of patients experience deep fatigue along with neurological and cognitive symptoms that make it difficult to drive, make decisions, remember instructions, follow conversations, and plan ahead. The Brookings Institute recently estimated that 1.6 million workers are out of the workforce due to long COVID, which represents an astounding majority of the estimated 2.2 million people that the labor force is missing from its pre-pandemic size. Even before COVID, ME/CFS, which is extremely debilitating and has significant overlap with long COVID, affected 180,000 Californians and cost our economy $5 billion annually in lost wages and medical expenses. There are only about 6 ME/CFS specialists practicing in California, which means that Californians like me, afflicted with ME/CFS, often wait up to 2 years before being examined by a specialist. Many never get to see one at all. And this trend is now absolutely occurring with long COVID. I'm in the mild end of the spectrum of disability of long COVID. I have been part of support groups and listening sessions and news reports with patients who are unable to work at all, who are homebound like me or even bedbound, unable to care for themselves because the act of making a meal leaves them with fevers and pains so severe they are completely taken out for the rest of the day. These patients have families and are often parents and breadwinners. Their access to benefits is non-existent because long COVID was not even a diagnosable condition until October, nearly 2 years into the pandemic, despite the medical research on post-viral conditions like ME/CFS, chronic Lyme, and even AIDS has existed to guide clinicians in caring for patients with infection-triggered sequelae. We must build on this existing research and not continue to frame long COVID as an entirely new phenomenon. My friend and colleague Hannah Davis from the Patient-Led Research Collaborative, who are studying long COVID, has said all of my tests came up normal until I went to an ME/CFS doctor, and then none of my labs were normal. That was true for me as well. I waited a year to see a specialist who could diagnose and treat my conditions, namely mast cell activation syndrome. And she has worked with patients with post-viral illness such as MCAS and ME/CFS for years and has a wait list a mile long. We also know that the virus has disproportionately impacted communities of color, both economically and in terms of their health. This means that there are likely millions of long COVID patients who because of income or immigration status, remain unidentified or unsupported with their new disabilities by the healthcare system, employers, and schools. I also did want to note that best estimates show that about 30% of individuals who have had COVID-19 reported at least one persistent symptom up to 6 months after infection. That means a conservative estimate in California is 2.6 million surviving COVID patients in California. 2.6 million patients are experiencing symptoms of long COVID, which are varied and obviously difficult to treat if you don't have a history of treating post-infectious chronic illness. So together with the disability and chronic illness communities, long COVID patients need California to do the following. The first is to address the clinical care crisis in long COVID and related post-viral illnesses like ME/CFS. California Centers of Excellence must be created. These centers should be located throughout the state and should provide adequate care, conduct research, and engage in education, training, and outreach. 2, policies that ensure that all patients with complex chronic illness have access to the best possible primary and specialist care, fully covered by private insurance and Medi-Cal, and in the case of COVID-19, regardless of having a positive test due to testing issues throughout the pandemic, especially in poor Black and Brown communities. 3, ensure that long COVID patients are able to access state disability insurance benefits, even if they do not have a positive test, given the persistent testing issues. 4, require commercial and public health plans with guidance from the California Department of Public Health and Cal HHS to conduct extensive outreach and education to providers and beneficiaries about the symptoms of long COVID and guidance on how to access care. 5, create incentives for providers and medical students, including Medi-Cal providers, to receive ongoing clinical education on complex and chronic infection-initiated illnesses. And finally, 6, stronger enforcement of employer and school accommodations for long COVID and other chronically ill patients who may be able to work or go to school if they have access to telework or distance learning, can have adapted schedules, are provided with reasonable accommodations, including masking requirements for their colleagues with whom they share indoor space, and have the opportunity to restructure their assignments or jobs. Thank you so much.
Thank you, Ms. Vasquez, and again, thank you also for sharing your personal story as well with all of us. And again, I know how challenging that is in this public forum to share something so personal as well. Let's now move on to Jennifer Stark, patient and managing attorney at Disability Rights California.
Good afternoon. Thank you, Mr. Chair and members of the committee for inviting me to speak today. My name is Jennifer Stark, and I'm the managing attorney of the Mental Health Practice Group at Disability Rights California. I'm here to speak about my personal experiences with long COVID and the importance of affording disability accommodations and protections to those who are negatively affected by it. Almost 2 years ago to the day, I became sick. At the time, I was on parental leave and barely leaving the house because I needed to care for my 4-month-old daughter, and I was already concerned about the virus. Had the state's lockdown orders gone into effect just 1 week prior, I likely would have been spared the virus and the continuing toll it takes. I was sick for approximately 3 weeks. While all my symptoms tracked those of COVID, I never received a positive test because tests were not available for people like me. I could barely leave the bed, but I did not require hospitalization. In the weeks after having COVID, I felt extraordinarily grateful for having recovered and moved beyond such a frightening experience. But approximately 2.5 months later, I developed breathing problems again. I wondered, whether I might have COVID a second time, a prospect that seemed nearly impossible because I hadn't left the house. I went and I got tested for COVID and for COVID antibodies, and both came back as negative. Doctors had no explanation for me. I was basically told just to take an antacid. Several well-meaning friends and family expressed disbelief that I had ever even had COVID or anything related to it. They wondered whether the extreme fatigue that I was experiencing, which was akin to having mono, was simply due to having a newborn. They questioned the seriousness of my symptoms, the recurring low-grade fevers, short-term memory loss, brain fog, difficulty breathing, racing heartbeat, digestive problems, anxiety, depression. According to them, because I was managing to keep working as a litigator and I didn't complain very often, I seemed fine. They assumed I was merely exaggerating or being a hypochondriac. When I went to a doctor to express concern that I had swollen toes that had turned purple and made it difficult to walk, they told me that I should just stop wearing flip-flops. This is the beginning of weeks, months, and now years of people disbelieving me and my experiences simply because science has not caught up to the lived experiences of people with long COVID. Since March of 2020, I have had recurring waves of symptoms that we now recognize as emblematic of long COVID. These wide-ranging symptoms have affected me from head to toe, and I have spent months trying to get doctor's appointments and meetings with specialists in what feels like a game of whack-a-mole. After waiting for more than 3 to 4 months to see neurologists, my symptoms moved from my brain to my lungs. By the time I got to meet with a pulmonologist, my symptoms had moved to my joints, and so on. I requested referrals to see the long COVID unit at UCSF, but initially I didn't qualify because I was never hospitalized. I'm now on the list for an appointment, which I scheduled more than 9 months ago, and UCSF has already canceled once. I'm still waiting. I've been living with long COVID for almost 2 years now and have yet to meet with any multidisciplinary doctors who can help me to understand the effect that long COVID is having on my body and what, if anything, I could do to treat it. The impact that having long COVID has had on me mentally and physically is hard to quantify. While I feel comparatively lucky, many people with long COVID have had far more debilitating experiences and have not been able to work at all. This has taken a toll on my family, and I've needed to take far more sick leave than ever due to unexpected and ever-changing symptoms and attending doctor's appointments. I've opted out of certain career opportunities out of concern that symptoms might return, and I might not be able to perform the tasks necessary. Despite these setbacks, I have been able to keep working because I have a job that offers flexibility and makes reasonable accommodations for people with disabilities. If I were in a different workplace that refused to offer these accommodations, I may have needed to quit several months ago. There's no question that this is one of the most disabling events in United States history. And the disproportionate impact that COVID-19 has had on underserved communities and communities of color, especially the Black, Latinx, and American Indian communities, makes the need to respond to this disabling event in a way that squarely addresses socioeconomic inequality absolutely vital. Based on my own experiences and the work I've done at Disability Rights California, there are many steps that California must take to address this crisis. We've already heard a few of those, and I just want to echo support, building on what several other panelists have already said. First, there needs to be clear recognition that long COVID can be deemed a disability under the Americans with Disabilities Act, which triggers the need to provide accommodations. Despite the often invisible nature of this condition, it must be clear to businesses, schools, and employers that people whose long COVID qualifies as a disability must be afforded the same protections from discrimination and reasonable accommodations as any other person with a disability under the ADA and the Rehabilitation Act. There also needs to be far more research on long COVID with a specific focus on underserved communities, communities of color, and people with disabilities and underlying health conditions. And as we've already heard, there is a need for expanded treatment options that include multidisciplinary treatment teams, centers of excellence, but a reduction of unnecessary barriers to treatment and reimbursement, such as eliminating the need for hospitalization or proof of a positive COVID test. And there has to be a continuous feedback loop with leading representatives of the patient communities informing research and policy decisions. While many of the problems that people with long COVID are experiencing are not new to the disability community, this is a newly political problem given how many more people are now going to be impacted. For me, the scariest part of all of this is that we have no idea what the future may hold. While I am thankfully only experiencing what seem to be minor long COVID symptoms right now, I have no idea what tomorrow, next month, or next year might bring. Whether long COVID will become a lifelong chronic condition for me or lead to early mortality, whether my time with my 2 young children will be cut short, or my ability to build a meaningful career will be halted. No one knows. I hope that others don't have to continue to navigate these terrifying questions in the way that I have, largely alone. Thank you.
Thank you, Ms. Stark, and thank you for sharing your personal story as well. And again, I know it's always challenging to do it in the public environment to share your personal stories. And I want to thank all of our panelists for being here and for sharing with us so that we, members of the legislature, can try to hopefully make progress and address the issues that you've raised. Okay, I'm not sure who had their microphone up first, but okay, Senator Leyva.
Thank you, Senator Pan. I just want to reiterate my thanks to these 3 amazing women who shared their stories, all at different points in their life. And I just hope, as hard as it may be, that they will keep sharing their stories, because I've heard of long COVID, but hearing the actual details and how disruptive it is to their lives, we all need to hear that so that we understand that it's real, that it's happening, and that we have to find a way to tackle it. I don't remember which of the 3 women stated that 1.6 million people are out of work right now due to long COVID. I think that was shocking to me, and it probably helps us understand why there is such a shortage of workers right now. When we add that to the almost 1 million people who have died due to COVID, it's no wonder that we're having a hard time getting the workforce back up and running. So I just wanted to say thank you to these three brave women, because if we don't know better, we can't do better. Thank you.
Okay, thank you, Senator Leyva. Senator Rubio.
Thank you, Mr. President. I also want to thank these wonderful individuals for sharing their story. I know it's not easy, but I think it's important that they do. What really stood out to me is I believe that some of the two ladies that spoke first said that they had already been boosted and then they got COVID again. And I just want to reiterate that, since there's so much misinformation, I hear it constantly from our youth and adults saying that they want to get COVID just to get it over with. And it's important to note that it's not just getting COVID, but it's also dealing with these long-term effects and the fact that they got it after they were already sick. I just wanted to make that point, that it's clear that you don't know if it's going to come back again. I heard it earlier today again. Someone wants to get COVID just because they will not get it again. Thank you so much for sharing your stories. I think that puts it in perspective, and I think that learning from your stories, we know that there's a lot of work to do, and we'll do what we can to continue the research and try to figure out solutions. But once again, thank you for your time.
Okay, thank you, Senator Rubio. Senator Wiener.
Thank you very much, Mr. Chairman. I also just want to thank the people today, but also in general, the long haulers who have been suffering often for the last 2 years, and who have been advocating, and sometimes I know it feels like they're yelling into the void. And especially for people who got COVID early in spring, summer 2020, when we knew we knew so little about this virus in general, and we were in a fire drill emergency triage mode to stop people from dying, to stop their lungs from dissolving effectively, and we were not, as a society, really paying enough attention to the people who had recovered and, in quotes, recovered, but were not really recovered, and were experiencing these long-term effects. And I know it was so frustrating for so many people, and it still is, in terms of getting treatment and sometimes getting the healthcare system to take them seriously. And we know that even before COVID, for people with post-viral symptoms, whether from mono or from other viruses, they were not taken seriously consistently, and people were told that they were just had a mental health issue, or they were just overly sensitive, or they were making it up. And I think there's nothing good about COVID, but at least COVID has shined a bright light on post-viral problems, not just for COVID, but for other viruses. And I really hope that this leads to dramatic investment in research to figure out how we prevent this from happening when someone has a viral infection, and how we treat people after the fact. So thank you for your advocacy, and please keep advocating and hold all of us accountable.
Any other questions from committee members? I did have a question I wanted to pose, and sort of came from the first panel, and maybe what I'll do is I'll start with first with Ms. Stark, because you also have your hat on as wearing disability rights, and I do see her. Actually, you know what? I see Stacey Gruder's hand up. So did you want to respond to one of the senators who just spoke? So maybe I'll let you go first, and then I'll pose my question. How's that?
Thank you so much. I think I appreciate the input from both of the other women who spoke on their journeys with us. I just think it's really important. One of the things that was brought up that never occurred to me, and my educational hat and my parent hat at the same time, that can be done probably very quickly, is to identify what we can do in our school systems to help these kids. Only because I'm an educator and I knew that we could go through the Office of Disabilities through my daughter through the university to get her extended time excused absences because some professors still, it's like, still, you know, you missed 3 classes, your grade drops, whatever, a different conversation. But I just think it's very important because at one point we were told by the university COVID will no longer be an excuse. And that was very startling because, so then we actually had to say, okay, she has anxiety. So that was a diagnosis they felt comfortable with to give her accommodations, but they did not want to use COVID as a way for her to get accommodations that she absolutely needed to have. And, you know, in an educational setting for K through 12, I know that we can do Section 504s, and that may be something that parents don't even know is available to them. Our teaching staff may not know that those accommodations are going to be necessary for some of these kids who are going to be struggling with this. I think it's very important to get that identified, so I just wanted to share that piece.
No, thank you. Thanks very much. And actually, that was kind of apropos to the question I'm about to pose, which I actually, well, maybe what I'll do is I'm going to start off with Ms. Stark, partially because also you have your hats on as being an attorney at Disability Rights, and then we'll have Ms. Vasquez, and then actually Ms. Gruters, if you wish to comment on it after hearing the other answers. So this whole issue about who qualifies for services, right? And you mentioned, Stark, you talked about the fact that you got COVID early on, so there was no testing available or very limited testing. And I remember when we didn't have any tests, and sometimes even now, sometimes that's a bit of a challenge too. So what do you see from a sort of policy point of view, from our perspective as legislators, we should be doing in terms of, I guess, being sure people have access to the services they need? How people will say, well, we need to have some gateway, right? We have to have some definition, something. It just can't be completely wide open. But and maybe but clearly, we also know that if we have definitions like you have to have a positive test or antibodies or something, and I think each of you actually talked about the fact that you had a bunch of tests and they were all negative, right? But you clearly have symptoms and so forth. How should we approach this from a policy point of view in terms of being sure people have access to services people who have disabilities related to COVID or long COVID or post-COVID disease? So how do we address that gap?
Thank you very much. I'll be interested in what other people have to say. I don't claim expertise in this realm, but I would say that some of what I believe Dr. Deeks mentioned earlier in terms of looking at symptoms seems like a really good approach, and also being really cognizant of the deficiencies in terms of recognizing what has normally been required to qualify and what does not work in this context. So as you said, recognizing that testing was not available and that there continue to be limits with testing, recognizing that hospitalization is not a proxy for whether or not somebody can have long COVID, recognizing that antibodies is not necessarily the proxy. So I think looking at what are the symptoms, even if it's imperfect, that tend to correlate with this, and not creating unnecessary hurdles and obstacles, particularly recognizing the tremendous socioeconomic inequality that prevents many people from going through and checking the boxes that might otherwise be necessary. But I would also be really interested in Ms. Vasquez's opinion, because I feel like she has even more experience in this realm. And I feel like I have, while I am an attorney and I can talk about what is required to make sure that people are, qualify as having a disability under the ADA, I feel like much of my experience here has been as an individual and as a patient. I guess I would just add one thing, though, that the frustration of feeling like I have the desperation for treatment, the desperation for credibility for people to believe what I'm saying, and not being able to point to anything tangible has been a tremendously challenging piece of this that has led to also, a lot of mental health challenges. And so I think just recognizing the way that stigma plays into this, and recognizing that, some of the need to define people can lead to adverse consequences, and also make it less likely that people would even seek care.
Thank you. And again, I think our experts had mentioned, our first panel had mentioned that certainly, even people with very mild or practically asymptomatic can also develop long COVID. So this idea of hospitalization is a threshold. Ms. Vasquez.
Yes, that's a great question. The first thing I'll note is that it's really important to remember that antibodies are not the best way to identify a previous infection. And in fact, especially in long COVID, there seems to be some sort of connection between not what's called seroconverting, not creating antibodies, or sufficient antibodies or timely antibodies, and long COVID symptoms. Again, probably not the thing that causes long COVID, but there's certainly some association, and it seems really prevalent in our community of long COVID patients, where despite no matter when we're being tested, we are not producing detectable antibodies. So I really, really want to caution policymakers from using testing as a means of gatekeeping both clinical care, research cohorts, and benefits based on testing, because it's just simply not sensitive enough to pick up even the majority of long COVID patients, I would say. In terms of, how do we ensure that folks are, truly sick to get benefits, I would challenge policymakers to think about the history of medical gaslighting and undermining patient narratives of their own illness, and really challenge the state and policymakers to believe patients, and they are the experts in their own experience and in their bodies. I mean, there's a huge history of not just undermining women's health experiences and diminishing their pain and their narratives of their own suffering, but there is also a very strong anti-AIDS movement, AIDS denialism, even just recently. So it is, for me, I think a clinical diagnosis, especially once it's developed, must be included in sort of benefits evaluation. For example, there's no test to define migraine, but there are people who are disabled enough by migraine to receive long-term disability benefits. And so I would really strongly encourage us, again, as policymakers, to accept that long COVID can be clinically defined by, someone who knows what to look for, by post-viral experts. And that's where I would push policymakers to go, is to create a strong clinical definition of long COVID, and then educate disability administrators and auditors, because often what I have heard from other patients, I myself have not applied for disability benefits, although I do have accommodations from my employer, that disability evaluators are often quick to undermine clinical diagnoses, even when doctors are very thorough and fervent in documenting a patient's disabilities. So I think there needs to be not just education on the clinician side, who are, supporting patients and applying for disability benefits, but we need a massive education effort on disability administrators and the auditors who evaluate these claims and make decisions, because I think also a lot of institutional gender bias and race and ethnicity bias often come into play when evaluating these claims as well. That's it. Thank you.
Okay. Thank you. And Ms. Gruters, did you want to make any additional remarks about this issue?
No, I think, I mean, they were both very well spoken, and I just think it's something to be very cognizant of, so that we make sure that those accommodations that are due to people that need them, especially in an educational setting, are available.
Okay. All right. Any other questions from committee members? Oh, yes, Senator Leyva.
Thank you. I just wanted to add on to what Ms. Vasquez said about believing people and believing women in particular, it kind of reminds me of fibromyalgia before that was readily diagnosable. I had a very good friend who it took almost 10 years for her to get that diagnosis. So yes, we have to be open to new things, and we have to believe people. I just don't think people go to the doctor because they have nothing better to do, and most people want to live their healthiest and best life. Again, thank you to all the members on this panel.
Oh, well, thank you all very much. And again, thank you so much for sharing your personal stories. Ms. Gruters, I'm hoping your daughter, Lauren, is going to get better soon. I know she's, and then also Ms. Vasquez and Ms. Stark, hopefully that your symptoms, hopefully there'll be some resolution sometime. Again, appreciate you taking the time, all of you taking your time out to advocate and to speak out so we can hear your stories and hopefully learn from them to pursue better policies. So again, thank you so very much. Thank you. All right, we're going to move it on to our third panel on statewide planning, preparation, response. So as we've been dealing with COVID, what are we doing to try to address long COVID? And please, we have two panelists. We have Dr. Erica Pan, who is the California State Epidemiologist and Deputy Director for the Center of Infectious Diseases at the California Department of Public Health, and Dr. Joanne Elmore, Principal Investigator of Innovative Support for Patients with SARS-CoV-2 Infections Registry at the University of California, Los Angeles. So we'll start with Dr. Pan. Welcome.
Good afternoon, Senator Pan and Newman and committee members. Thank you so very much for having me this afternoon. I wanted to pause also and just echo the huge thanks to the prior speakers for sharing their experiences. It really is helpful and meaningful to all of us and takes a lot of courage. So thank you very much. I'm here today to provide you with information about the state's efforts to assess, study, and prevent post-COVID conditions, and also highlight some of our activities and plans to evaluate and address the broader impacts of this devastating pandemic on Californians. As we transition into this next phase of the pandemic and implementation of the SMARTER plan, there are several key areas for California to focus on. In addition to understanding the direct physical and mental health consequences of infection with SARS-CoV-2 that we're discussing today and focusing on, we also need to understand the long-term health, economic, and societal consequences of living through this pandemic for both survivors and those who did not experience infection. We need to address research and analyses on the relationship between the pandemic and community-level social determinants of health, as well as evaluation of the effectiveness of economic, employment, and other social policy measures on mitigating the negative effects of the pandemic on communities and individuals. Finally, there needs to be an infrastructure to support public health and academic collaboration to align and prioritize applied research that benefits all Californians. We're posting a concept paper today to outline our initial thoughts on how our state should use this opportunity to build on and expand our academic partnerships to develop a sustainable infrastructure to collaborate and launch a long-term impact study along with other research analyses to help us learn from this experience and be better and more prepared for the next surges and future public health emergencies and pandemics. While we're continuing our response to the acute impacts of COVID-19, we are involved in efforts to understand and address the long-term impacts of COVID-19, the focus of our hearing today. There have been more than 8.4 million reported cases of COVID-19 in California, and almost 900 cases of multi-system inflammatory syndrome in children, including 8 deaths. Because not all cases are reported, the actual number of infections is much higher. While the proportion of persons with COVID-19 to develop post-COVID conditions varies between studies, as was recently discussed, it's likely that a large number of Californians will be affected. We also know this disease has disproportionately impacted some populations, magnifying pre-existing disparities. While the long-term burden of post-COVID conditions is not fully known, the COVID-19 pandemic has the potential to be an enormous disabling event, in addition to being a cause of acute illness and death. So what is the California Department of Public Health doing to educate and intervene? Prevention, of course, is still incredibly important. Studies have found that vaccination remains the best way to prevent infection with SARS-CoV-2 and prevent the development of post-COVID conditions. CDPH is working to promote vaccinations and boosters to stay up to date as the key element to prevent post-COVID conditions, as well as recommending masking that has good fit and filtration. As our SMARTER plan lays out, after shots and masking, awareness is the next essential strategy. To that end, we have taken several activities to keep assessing, communicating, and coordinating on post-COVID conditions. Some of these awareness efforts include working in collaboration with UCSF and UCLA on the INSPIRE study, which you'll hear a lot more about with Dr. Elmore, a CDC-sponsored study, and again, she'll describe that in more detail. We've been collaborating with UCLA since August of 2021 and with UCSF since December 2021. And our partnership with the academic institutions in California ensures that a representative sample of the state will be included in the INSPIRE cohort. And again, you'll hear more about that with the next speaker. As far as communications, we've developed some frequently asked questions. We just recently launched a webpage and social media materials to address concerns about long COVID. It just went live on February 25th, 2022, and we will provide that link and can add it to the chat later as well. We've also partnered with Resolve to Save Lives to share the Voices of Long COVID campaign, which contains firsthand experiences of people struggling with post-acute COVID, and it focuses primarily on the 18 to 22 age group. The videos and social media messages in this campaign are part of our long COVID communication toolkit, which is assigned to be used by local health jurisdictions and other partners. And I encourage, again, the other speakers to take a look at this as well. And just as today, I think these personal testimonies are some of the most meaningful ways to get the message out to people. We're also planning outreach to healthcare providers and the public, as well as general education materials. We're preparing these and expected to be ready in the next month or so. We have materials planned, including informational flyers, brochures, additional online content, and training webinars about long COVID. And then for other interagency coordination, we're participating again in the University of California Long COVID Working Group, initially convened by the UC Office of the President to coordinate post-COVID care and research across the UC system. We've been invited to join due to our existing relationship between UCOP and our department, as well as the developing collaboration with INSPIRE. Some other possible next steps are to expand our surveillance efforts. So we want to adopt a multifaceted approach to measuring the burden of post-COVID conditions in the state. There are different strategies that will be needed to assess the impacts and of the COVID-19 pandemic in California. We could actually work to develop a California consensus case definition and consider making post-COVID conditions a reportable disease in California. We also could use a case control study framework to gather data on post-COVID conditions, and this would allow for data collection from a representative sample of state residents with and without history of infection. And then as I opened with, we really also want to study the broader societal implications of this pandemic. We are considering methods to assess that broader impact and hope to launch efforts within the next 6 months. Some important questions to consider are the impacts on persons who lost family members, deferral of care for chronic diseases, deferral of health screenings, mental health impacts, and loss of time in school for children. We will partner with federal and/or academic organizations on broad surveys of people in California, policy assessments, and other collaborative research to assess the impacts of this pandemic on Californians. We're very cognizant of societal implications beyond public health, including the need to consider accessibility, adaptability, and accommodations in survivors' daily lives as it relates to education, employment, and more. Our posted concept paper asks for additional input and feedback by March 18th, after which time we'll launch a work group with partners and further define priority studies to resource and work on. And I will stop there. Thank you very much.
Okay, thank you so much, Dr. Pan. Now let's move on to Dr. Elmore with the UCLA. Welcome.
Thank you. Well, I was asked today to talk about the INSPIRE study, and I want to step back and say that one of the benefits of the pandemic is it's bringing us all together. It's bringing legislators and patients and family members and clinicians and scientists. We all have a common goal, and we want to work on this together. And I think by joining forces, as UCLA has done with the California Department of Public Health in our one study, I think together the outcome will be better. So it has been a pleasure collaborating with the state. I will refer everyone to our website for UCLA study. It's Inspire Like to Breathe, INSPIRE. We're recruiting quite a few thousand patients, and we hope to have information that we can share with the state in the next few months. We are recruiting patients at the time of COVID testing, and a unique feature of the study is that we have both COVID positive and COVID negative individuals, so we have a control. I was asked, in thinking about what you wanted me to say today, I was asked to talk about what we know, what we don't know, and what my suggestions would be. So to start with what we know. We now know long COVID exists. And this is a monumental step forward because truly a year ago, physicians and scientists didn't believe in such an entity. And this is important. And this validates the really heartfelt comments by our three earlier speakers. Then the second topic is what we do not know and what we need to study. Almost everything. There is basically an information void. We do not know what are the main features of long COVID. We don't know how common it is. And I know you were asking earlier speakers what their estimate is of what percentage it might be. Even if it's only 5% of people that get COVID have long COVID, that is an astronomically large and impactful number. So the percentages that are being reported, 5, 10% to 50%, we don't know. We don't know if in the future, 10 years from now, we may see long-term effects from COVID that we hadn't even anticipated. Think about shingles that many of us deal with decades after. We don't know how to diagnose long COVID. Now, this may seem strange to some in the audience. We have a CDC and a WHO case surveillance criteria, and these are useful when you're studying things. Before we knew what caused AIDS, we had case criterias. Before we knew how to diagnose Legionnaire's disease or Lyme disease, we would have case criterias and surveillance that we then would study. But that is not the same thing as when I'm a doctor and I'm seeing patients in clinic and I want to know, how do I diagnose? I don't have a blood test. I don't have an X-ray that will definitively tell me that this is due to the early COVID disease. And we need help. We don't know what the risk factors are for the development of long COVID, and we don't know how to treat. There's basically this information void. It's kind of like a perfect storm. Patients and their families are anxious and suffering. There's not adequate support for the healthcare providers and the health system. We would like to see more patients. We don't have capacity. And we need to support collection of higher quality evidence. In addition to being a physician and seeing patients in clinic, I'm also an epidemiologist. And now that we've had the pandemic, people have heard of that word, an epidemiologist. I basically like to study how to diagnose and treat diseases and how to do a better job. And I have to tell you, as an epidemiologist, studying long COVID is not easy. There are so many reasons. It is uniquely challenging. One reason has to do with all the ways it has changed over time. Early on, we couldn't even diagnose. We didn't have diagnostic capabilities. Then there have been these new additions of different treatments that have come into play. We don't know how those will affect subsequent long COVID. Then we have new vaccines. Now we have different variants. And so we need to learn how these evolving changes over time are going to impact long COVID. I will refer the audience to a paper that I published yesterday, actually, in the Annals of Internal Medicine. It's short, only 2 pages long, and it describes some of the challenges that scientists are going to have. And we need to pay attention and be careful in studies. I am worried that some of the early studies have been low quality. And I think we need to do a better job. Patients deserve it. And it has been mentioned by others, disparities in health and healthcare. The pandemic is making it worse. And I'm very concerned as a physician and as a scientist. The burden of the pandemic, including higher infection rates and higher hospitalization rates, it has fallen disproportionately on individuals who are already vulnerable to inequities in health and healthcare. So we have long known disparities, and I think that new inequities in both the development, the presentation, and documentation of long COVID, I think it's going to accentuate problems. The evolving long COVID case definition, it's going to be influenced by patients that we're seeing in clinics. Not everybody can get into clinics. It's going to be influenced by who's participating in research. And because marginalized groups often receive less timely diagnosis and they often have their symptoms unrecognized or undocumented, I'm worried that long COVID may be underdescribed in those who are already vulnerable. I'll close with 3 practical suggestions for our state. First is really, self-evident. Our best defense in preventing COVID is with vaccinations. And so I encourage us to continue our really impressive statewide education and outreach efforts. My second suggestion is really simple. We need smoke detectors. Millions of people in the US cannot smell now because they've had COVID. This was one of the first long COVID, symptoms that became apparent. I've diagnosed COVID in patients that called me up because they said they had a cup of coffee and they couldn't smell the caffeine in the coffee and they wondered why. And I said, go get tested for COVID, and they had COVID. And now a year later, they still can't smell. In addition to having a reduced, quality of life, your sense of taste, your enjoyment, you can't smell the flowers, you can't smell fires. And so a simple suggestion is ramping up our educational efforts regarding smoke detectors. It's estimated that there are millions of people in the US now that have reduced sense of smell, this anosmia. The good news is that 95% of people that have it, it only lasts for a few weeks to maybe a few months, but it's thought that 2 to 5% have persistent. And we don't know how long, but I have some patients that it's definitely persistent for 2 years. Now, my final suggestion will be resonating with the earlier comments. It has to do with these centers of excellence. For many years, I have worked in doing research in cancer and HIV and seeing patients with cancer and HIV. And in the US, we provide outstanding quality of care, and we have amazing strides and accomplishments that we've made in research endeavors. But that's because these are usually done on the backbone of comprehensive cancer centers or centers of excellence for HIV care. We were understaffed and underpowered. I think a lot of the long COVID patients, they need to get funneled into primary care to start with. And that is because there's such a wide range of symptoms that are associated with long COVID. Then we need care coordinators at these centers that can help navigate to all of the many subspecialists, from cardiologists to neurologists. We then need support for physical therapists, rehabilitation therapists. Then we need social workers to help these people with the quality of life and financial issues. I think the University of California health system is poised to take on such a role. The UC system, it's really a crown jewel in our state. It's large, it's massive. And the health system is associated with academic powerhouses for research, the schools of medicine and the schools of public health. This network is unlike any other in the country. So I would really want to second or third this idea of centers of excellence. I should say, though, that I heard some of the patients talk about how they couldn't get in to see anyone. That is a real issue now, and it's only going to get worse. Many of the physicians are volunteering their time trying to help out. And so I really think that going forward, all working together, I'm hoping that we can improve this. I want to thank everyone for bringing the topic of long COVID to the forefront. We have a long haul ahead of us, and I appreciate everyone's support and encouragement. Thank you.
All right. Thank you so much, Dr. Elmore. Questions from committee members. Senator Newman.
Thank you, Mr. Chair. So, first, thank you to both of the panelists. Dr. Pond, it's been just a pleasure working with you as one of the leaders of the legislative coordinating group over the last year. And thank you for your participation today. And also our compliments. We've all been complimenting you on those wonderful glasses that match your background so well. And Dr. Elmore, to your point about losing one's sense of taste and smell, I actually had COVID, and I lost my sense of taste and smell for a couple of days, and it's hard to appreciate unless you've been through it, just how impactful that is. So building on that, I'd like to ask both of you to speak a little bit about the mental health dimensions of long COVID, particularly as we think about the ways in which we should integrate and coordinate mental health services in addition to some of the other physical needs that have been addressed today. So I'd be interested in both your comments there.
Sure, I'll start and just say, absolutely, I think, and some of the emphasis here is how multidisciplinary this is going to need to be, not only for the health and mental health, but all of the other impacts as well. So there are a lot of efforts to improve overall integration of mental health and medical health. And I think, as Dr. Elmore mentioned, I think we're just scratching the surface on a lot of the impacts of long COVID and other impacts of COVID in general. So I think, again, our intent is to be very multidisciplinary across different health disciplines as well as other social services, other policymakers, et cetera.
The pandemic itself has led to an increase in mental health issues, certainly made a lot of people depressed and anxious. I think that this obviously will need to be a key component of these centers and support. Voices of the patients need to be heard with compassion, and they need access to information and access to clinical trials. And I think if our community hears that we want to all work together, it will be better in the end. But if you think about depression, we also have a problem with the healthcare workers. They're tired. It's been a long 2 years for everyone.
I appreciate that. Thank you, Mr. Chair.
Okay. Senator Leva.
Thank you, Senator Pan. Thank you to both of the doctors for their expertise. Dr. Elmore, I had a question. When you talk about that we don't know the main features of long COVID, how are we going about figuring out what those are? This is going to seem overly simplistic. I'm not a doctor. As people come in, do you ask them, did you have COVID? And then maybe it's kind of like a checklist of what they have and don't have. And then do you cross-reference that with what other folks have to hopefully come up with some data in the future that can help more easily diagnose long COVID?
Oof, that's a good question. I suspect in the end, there are going to be many different types of long COVID. Some patients may only have anosmia, the inability to smell, but that is very impactful. Others may just have neurologic, some may have cardiac, some may just have dermatologic. And in the studies, for example, in the INSPIRE study, we are having patients fill out surveys, a really long list of symptoms, and they check off what symptoms they have. And then we're following them forward every 3 months to find out, are those symptoms still present? Are they going away? Or are they developing new symptoms? And when you are able and have thousands of patients participating and helping you in this study, you then can compare the rate of symptoms in those that had COVID to the rate in those that were COVID negative. We're recruiting patients at the time where they think they're symptomatic with an acute COVID infection. They've got a fever, a cough, don't feel well. And then we take them regardless of whether they're COVID positive or negative. And so this way you have controls. And there's a certain low rate of background, a small number of people have headaches, et cetera. But when you can compare the rate going forward over months to a year or two, and you see 5 symptoms pop out as being statistically significant and much more common in people that had COVID, that's how you get the answer. But you're right, it's very confusing. And scientifically, it's a mess. All of the publications are using different definitions. And so it's hard to compare. It's like you're comparing apples to oranges.
Thank you very much.
Thank you. Senator Rubio.
Thank you, Mr. Chair. I have a similar question to that of my colleague that just asked a question. It just seems that the information is all over the place, and rightfully so. This is something new, and everyone's dealing with different things. But just based on the stories that Stacy and Angela and Jennifer shared, Clearly, there's a lot that we're learning from these cases, and in particular, the Inspire study. I'm just curious, how are we getting information down to local health departments? I know that you have the information and you're learning as you go, but I'm just still trying to figure out, how do we find a centralized place where all this information is readily available for everyone, at the local level, so they can continue to sort of monitor in their own way? Is there connections? Can you help me understand, how are we connecting all the pieces from local health departments to our state, to the study that Inspire is doing, and all these stories that we're hearing from patients? How are we making sure that everyone's hearing the same thing instead of everyone? And I think I heard you say it's a mess, we're all over the place. That was something you said. How do we bring it together? I want you to help us understand, or help you. How do we bring it together so everyone has the same information?
Yeah, I can take that on, or at least start. I think, certainly at the state health department, we work very closely with our local health departments. We've done a couple, actually recently, presentations to our local health departments about kind of the work we're doing, especially this new outreach efforts around the public communications and more information. And then as this evolves, and one thing I mentioned, just to reiterate, and we'll of course be talking to, if the CDC is going to come up with a common case definition or not. There's been a lot of discussion today about the challenges of that, but if we do that either nationally or at the state level, we can work to collect that data more comprehensively at a minimum within California, and then work with our partners to kind of research and assess. The other thing that actually we have just launched recently as well is in kind of our statewide system that has cases and contacts in it. Actually, there are ways to kind of send automated surveys about post-COVID symptoms. So that is something that has been launched. We're just now starting to increase utilization of it, but it's another way we can try to have more consistent data collection across the state. And then of course, as mentioned earlier, but really the other kind of link that needs to be there is healthcare providers that are seeing patients, and really having all of the all of us really coordinating and working on that together. Thanks.
And I can add to that the University of California Office of the President, they have convened healthcare providers from all of the University of California schools of medicine. And we have regular meetings. We are sharing best practices, for at least what we think is the best practice, with this void of information. And we distribute the information to all of the academic health centers for every organ system, like for someone that comes in with neurologic symptoms, or someone that comes in with cardiac heart rate instability, or someone that comes in with change in their toes colors to purple. What is the suggested standardized evaluation? And what are some early ideas for treatment options that might help? And so we're trying to share information, and we've even had discussions on how we, as educational institutions, we have a commitment to help educate all of the many other providers in our state who don't have access to the same information we have. I know just a week ago, I was giving a talk to all of the mental health care providers for the Department of Mental Health in LA County. I gave that talk with a professor of neurology and a professor of psychiatry at UCLA. So we're slowly trying to get the word out, but I think your question is something that we need to consider further. So thank you.
Okay. Any other questions from committee members? All right, I just have maybe one very brief question, and we are sort of coming close to the end of our time, so I want to be sure we get enough time for our last panel here. But so I'm a primary care physician. I was at UC Davis, and I can imagine the primary care doctors listening to this, and again, very sympathetic to all the patients. When the experts are saying, well, it's still a mess what the definition is, and then meantime, we're expected to fill out paperwork certifying at the risk of blah, 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 license, et cetera, that someone meets qualifications for disability, et cetera, and it's still sort of vague out there. What kind of support are we going to provide to primary care physicians to be able to, they need an access to multidisciplinary team, all right? They can try to put one together through referrals, but we probably need to, given the numbers that's happening, we need something more systematic so that the primary care physicians can have more confidence that actually can help the patients more as well, I think. We're not trying to gatekeep, we're just trying to figure out, but oftentimes the burden of quote unquote certifying and so forth falls on these primary care physicians who want to say yes, but then at the same time They feel like that, I can't do the whole evaluation myself, and especially if the experts that we were hearing from, they're like, it's all over the map. Well, how's a frontline primary care doctor supposed to figure it out on their own, right? So maybe I guess the question is that, or the suggestion is that the state set up multidisciplinary evaluation teams that primary care doctors can refer to, whether it's through UC or something, but we're gonna have to have a lot more capacity. We can't have like, oh, by the way, the next appointment's 6 months. Just, I guess, in the same way we have, for example, in DD, I can refer someone to a regional center. I may make an initial diagnosis, I think the child has autism, some other developmental delay, but actually they can do an evaluation and start beginning services. So is that, maybe I'll ask that of Dr. Pond, is there some consideration of that going on in some of the discussions over at state? I wouldn't necessarily sit in CDPH, but are you aware of discussions of that nature?
I'm not aware yet of any of those discussions, but I can take that question back and follow up.
Okay, all right. And then I don't know, at UC, I mean, again, I know we've heard from UCLA, et cetera, but I mean, is there some thought about basically, but it does mean opening the doors. You have a lot of primary care doctors out there saying, I'm trying to struggle. I have a patient who seems like they have long COVID. They don't have, tests are negative, blah, 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 et cetera, but who can I send them to get a more definitive evaluation? And I'm able to do in my office.
Well, we have a tsunami of patients that want to get in and that will be coming. And
right.
It would be helpful if in the state there was better support for this. So thank you.
Okay, so it sounds like an idea. I mean, I realize that doesn't solve all the workforce issues, but again, how do we be sure we assure access to services, et cetera, and how do we provide support, to people so that we can be sure at least we can get them qualified for existing services, obviously, as well as developing additional services that are necessary. All right, seeing no other questions, let's thank you so very much, both of you, for your presentation. Looking forward to following up, and again, also appreciate the presentation on the Inspire registry as well. It's going to be extremely valuable to all of us. Thank you. All right, we're going to move on to our last panel on long-term costs and consequences, and very pleased that we have Dr. Greg Vanish-Karshorn, who's medical director at Mayo, the Mayo Clinic COVID Activity Rehabilitation Program, and then also Dr. Jennifer Chavinsky, who's a Deputy Public Health Officer at Riverside County Department of Public Health, who's also published numerous papers as well, articles around the long-term cost consequences of COVID. And so let's begin with Dr. Vanish-Karshorn from the Mayo Clinic. Thank you so much for being here and speaking to us in California.
Great. Members of the Senate, colleagues and patients, thank you for sharing part of your day with me. I'm really honored to be here. So again, my name is Greg Vanish-Karshorn, and I'm an occupational and aerospace medicine physician at the Mayo Clinic in Rochester, Minnesota. I'm also the medical director for our COVID Activity Rehabilitation Program, and we've had the pleasure to visit with patients suffering from long-haul COVID since about May of 2020. And I wanted to share some insights into long-haul COVID from my perspective as an occupational medicine physician. We've heard today from many colleagues and experts, and most importantly, the patients, about the kinds of symptoms that people experience with long-haul COVID. And their stories are accurate with what we have seen also in our patient populations here. In this slide, you can see a distribution of the kinds of symptoms that we have seen in the patients in our CARP clinic. And again, at the very top are fatigue and respiratory complaints. But that's only the tip of the iceberg. We also see a fair amount of neurological issues, a lot of brain fog as well, and sleep issues, as well as troubles with mental health. Now, when most people think about long-haul COVID, what they think about are the symptoms like this. But in reality, this is only one half of the picture. And the other half, and what I would argue is even more important, is how this condition really impairs the ability of a patient to live their lives. This is something that we've been focused on from the very beginning as an occupational medicine clinic. At their time of presentation, over 30% of our patients reported difficulties with some of the most basic activities of life on a daily basis. Things like being able to take a shower, or being able to put their clothes on or use the bathroom. 82% reported difficulties with the more routine things like going grocery shopping, or taking care of household chores, or going to work. Now, 63% of the patients that we have seen in our clinic had been able to get back to work by the time they started care with us. And that sounds promising, but it's important to note that at the time that we did this survey, the average time between the infection and presentation with our clinic was 3 months. So another way to look at this is that after 3 months from an infection start, only a little bit more than half of patients are getting back to their livelihood. On top of that, of those patients that are back, many of them were working reduced hours or had other kinds of work restrictions. Now, again, this is what we have seen here in our own clinic, but this is also consistent with what's been found in other clinics across the United States and across the world. So, for example, in Mount Sinai, which is one of the first long COVID clinics in the country, this is a diagram that comes from their patient population. And what you can see in the dark bars are employment status before COVID, and the light gray bars after. And what you can see is, of course, the full-time work is decreasing as time goes on. Part-time work goes up, rates of employment go up, and those who are retired go up. And as for the longevity of these kinds of functional limitations, there is not good news. As was mentioned earlier, we're almost now 2 years out into trying to manage this condition, and we do have information now about how patients are doing over the long term, like this study that came out of New York, looking at how 530 patients were doing 12 months after they were discharged from the hospital. And what we see from that survey is that 41% of patients reported worse health still than their baseline before COVID. 45% almost had persistent symptoms. More alarming, their function was also limited. 36% reported difficulties with carrying their groceries. Almost 40% had troubles walking up a flight of stairs. So the functional deficits, they can stick around for quite a long time. A question I'm often asked when this information is presented is, why are patients with long COVID losing their jobs? Most would think that the answer is primarily time. Patients are just not getting better fast enough. However, it's important to note that getting someone back to work involves more than just making someone feel better. There are multiple factors at play when it comes to that interaction between work and health. I mean, it's why I have a job in this career. For example, many employers are very confused about what they can do to help employees with long-haul COVID come back to work successfully. The usual response by employer groups when challenged with this condition, well, please don't come back until you're 100% better. Well, I don't know if any of us start the day with 100% feeling well when it comes to our work. So this is a very difficult challenge for many employees. So it's important to realize again that there are so many things that are left to be addressed in addition to medical care to help people get back to their livelihoods. In the meantime, with this kind of data and based on what we have seen in the clinics, I am worried that we're going to be facing a tidal wave of patients unable to return to work for a prolonged period of time due to long COVID. And I really fear what this may do to our world as we know it. We did have a preview of what could happen during this last holiday season. Many of you may remember that there were thousands of holiday flights seemingly canceled at the worst time due to due to flight crews and pilots being out of work due to Omicron. We also heard stories of fire departments in Cincinnati having to work overtime because of the staff shortage. So there is a potential impact on our world, our society, our economy due to the number of people who are suffering from long COVID. Now, of course, the workforce issue is only one of many challenges, and many of my colleagues today have mentioned some of these already. So I'll just in brief, one thing that I do worry about very much so is that we are not seeing all patient populations represented in this group, including individuals who are coming from other kinds of jobs like more labor industries and so forth. We also don't have a good way of assessing impacts across the nation or in a statewide fashion. We don't have enough providers to help manage this condition, and probably most alarming, this is not rare. To give you an idea of the kind of problem that we have ahead of us with this, currently, as of this week, there have been 79 million COVID-19 cases in the United States alone. Here at the Mayo Clinic, just like our first presenter, we estimate conservatively, based on the research, conservatively estimate that 10 to 20% of individuals with COVID-19 are going to come down with long haul COVID. So that's 7.9 million people. Based on our clinic experience, as well as the research that is out there, we anticipate that 30% of those individuals will have long-term difficulties getting back to their normal work. And that is roughly 2.37 million people out of work due to long-haul COVID for many months or indefinitely. So the challenge ahead of us with long COVID is more than just a healthcare challenge, but a challenge for our society and our economy as a whole. With that, I will pause and yield to our next presenter.
Thank you. Dr. Shavinsky. Welcome.
Thank you. I appreciate the opportunity to speak today about long COVID. It's a topic that I've been researching before there was even a name to put to the symptoms. As you've heard here today, it's important to understand that not everyone has the privilege or the opportunity to be able to return to life as usual. There are Californians who are suffering. My name is Dr. Jennifer Shavinsky, and I'm a double-boarded preventive medicine and lifestyle medicine physician serving as a deputy public health officer for Riverside County. We've had more than 6,300 COVID-19 related deaths. I oversee the Division of Infectious Disease, Community Health Planning and Equity, and serve as the medical advisor for our local COVID-19 response. I'm speaking also on behalf of the California Conference on Local Health Officers and the County Health Executives Association of California. Before joining Riverside County around 6 months ago, I worked at the CDC as an Epidemic Intelligence Service Officer, where I was deployed to the late sequela or post-COVID condition unit. In this role, I wrote the CDC's interim guidance for healthcare providers, evaluating and caring for patients with post-COVID conditions, with feedback from Body Politics, Survivor Corps, and the Patient-Led Research Collaborative. I've also authored multiple publications on post-COVID conditions, or long COVID, and helped inform the decision to consider long COVID as a disability and to create an ICD code for post-COVID conditions. While at times COVID-19 is looked at as a virus that people either survive or die from, there's a lot that falls in between. Data has shown that there are widespread impacts to physical health, mental health, and quality of life. And while it was once thought that COVID-19 was primarily a disease of the lungs, we've come to learn that the effects of COVID-19 are much more widespread. People can experience a vast number of different kinds of symptoms, as have been described throughout this hearing. Many of these symptoms can be difficult to describe, and studies suggest that long COVID may be more common in women, and so it becomes even more important for us to pause and listen to these experiences and take them seriously, as historically we know that women, particularly women of color, have unfortunately experienced medical racism and sexism where their symptoms have been dismissed. Importantly, just as there have been disparities in COVID-19 cases, it's anticipated that similar disparities have and will exist for long COVID. This means that our communities of color are likely to experience historical and current disparities not related to COVID, disparities related to acute COVID-19, and then on top of that, also additional burden of long COVID. Some of the key activities that health departments have done and will continue to do in order to prevent long COVID include the same activities that help prevent COVID-19. Throughout the pandemic, health departments have been on the front lines to provide vaccination, testing, novel therapeutics, as well as guidance on masking, isolation, quarantine, ventilation, and hand washing. We know that these strategies work, and we strive to provide these programs and this guidance, centering equity in our mission. Many of these aspects are found and highlighted in California's Smarter Plan. Other activities that county health departments can and have done involve their roles as expert conveners of community partners and resources. They can use their communication platforms to share information about long COVID on their website, either directly or by linking to the CDPH website, post information on their social media platforms, and share information about local post-COVID care clinics, disability benefits, and recommendations on flexible work and school policies. With some of this groundwork that's been done, health departments can help share and bring this information to their trusted community-based organizations, faith-based organizations, schools, employers, and others. Local health departments are great at convening groups, connecting the dots, sharing information, and partnering with the community. Some of the more specific initiatives that we've partnered on here in Riverside County include conducting post-COVID follow-up calls, tens of thousands of calls, to learn about the long-term experiences that our residents have after testing positive for COVID-19. Partnering with members of our African American Collaborative on building support groups with trauma-informed approaches, and hosting training sessions on long COVID for our promotores and community health workers who have been integral trusted messengers throughout the COVID-19 response, reaching our Latinx community, including migrant and agricultural workers. And actually, in our county, we've personally felt the effects of long COVID, as one of our promotoras has experienced ongoing effects of long COVID, such that she hasn't been able to go back out into the fields and continue doing the great community work she has so much passion for. This ripple effect can be felt throughout the community. We must continue to build strategies around long COVID into our recovery plans, centering equity at the core of these strategies. We must learn from lessons of past post-viral conditions, like the experiences from post-polio or West Nile virus, as well as from communities that have long suffered with conditions that are often downplayed, like those experiencing ME/CFS or myalgic encephalomyelitis and MCAS. More studies are needed, that's certain, and it'll likely take time before centers of excellence are established. But in the meantime, we need to help those who are suffering now. So with your support for our staff and programs, we can prevent new COVID-19 cases now, and we can share current best practices and resources now. Your continued support with planning and budgeting for services can help us grow these initiatives and achieve these goals not only for the community, but with the community. California has and should continue to take the lead, putting the needs of Californians at the front. So I thank you for your time.
Thank you so very much for your presentation. Questions from committee members? Okay, actually, I do have a question for you, but before I ask my question, as this is the last panel, I do just want to invite the public who wish to participate in public comment. We do have a hard stop time at 3:30. If they want to call in now, please dial the toll-free number 844-291-4185 and use the access code 126-5218. So just wanted, if people are calling in, this is a good time to do that. Dr. Vanishkashorn, you mentioned just sort of, I guess, your estimate of essentially around 2.4 million Americans unable to work potentially from long COVID or post-COVID. And that's, as you mentioned, I think we're about 79 million COVID cases, although, of course, some people say that's probably an underestimate. But I think at least I've seen, and please correct me if I'm wrong, because I'm not, probably roughly a little under half of Americans have probably had COVID, potentially. Again, it's a bit of a guess. We know there's 79 million who actually, at least cases identified. The actual number perhaps is a little bit higher. But that also means, let's say about half or a little over half of Americans haven't had COVID. As we're looking at the numbers of long COVID and we have a range of frequencies and so forth, what should we be working harder to prevent the other half from actually, or a little over half from getting COVID in the first place? I mean, we've been talking about all the service and so forth, and we need to do that because there's so many people who already have gotten COVID or already have long COVID. What should we be doing to, some people said, well, hey, it's okay, people can get COVID and we'll deal with it later. But what you're telling me in terms of the burden, should we be working harder to try to prevent COVID so that we don't keep adding to this burden of long COVID?
Yeah, it's a great question. Thank you for that. And I think there's three main points there that I'd like to just touch on briefly. Mm-hmm. First, yes, the numbers that we have for these estimates, they're estimates, just that. And there are many people out there who may have had COVID, who didn't have access to testing, especially early on in the pandemic, who may be experiencing these symptoms and are falling through the cracks, and we may not know about them. When it comes to the next point here, when we had Omicron surge, a lot of people took solace in that this condition was, or this variant treated individuals less severely. But as we have heard multiple times over today, a severe infection is not required in order for someone to have long haul COVID. And this is often still very surprising to many individuals out there. So I think that education about who can get long haul COVID, who's at risk for this, and how long it can really last is something else that we need to focus in on. And of course, there's also the vaccination. By far, the best way to not get long haul COVID is to not get COVID in the first place. And continuing our efforts to make sure that individuals are properly vaccinated and that we continue to do the research into the proper vaccines are going to be important as we go forward.
Thank you. And Dr. Shavinsky, I mean, you described in your background, of course, you were working at this CDC, but you're also speaking on behalf of the local health officers and the the county health departments. We did hear from the state about some of the things that they're doing. What are some of the things that local health departments are doing, and what do local health departments need from the state? As you're speaking to state senators here, what do you need for as county health departments and as health officers to help support you in both dealing with long COVID, addressing long COVID, but also preventing long COVID so that we don't keep adding to the numbers of people with long COVID?
Sure. Well, from our side, as we have throughout, our time dealing with the pandemic, we're still working on vaccines. We're still, working on testing. We're still, working on therapeutics. So support for those ongoing activities is vital. And what that support looks like, that's also help with staffing. So we've had some staffing concerns over time. So building up the workforce and having funding to help do that can really help us to accomplish our ongoing activities with the COVID response. But then also as we branch into, newer activities around long COVID too. There are efforts that we already have underway, as I mentioned in Riverside County, a lot of those focused around the equity components and reaching into our Latinx community, our African American communities, our American Indian communities. So being able to have the staff and have the resources to be able to expand on our long COVID efforts would really be very helpful as we try and make sure that everybody throughout the community has this information into the schools, into the employment sectors, and most importantly, into the areas that are otherwise have large social and economic barriers.
And maybe the follow-up, as you talked about equity, to what degree do you think perhaps long COVID may be underdiagnosed in communities of color and low-income communities? I mean, we talked about it's hard to define. People, as we try to estimate the numbers, and I know that there's sort of wide variation, but also if you have less access to whether it's primary care doctors, of course, that means even less access to multidisciplinary teams and specialists and so forth. And then, of course, we talked about less access to testing and other types of things to identify whether you even had COVID in the first place, and how often it turns out someone may necessarily not have a positive test and still have long COVID. Can you maybe speak to what we need to do to assure that we're actually identifying people with long COVID who are identifying what the burden of long COVID is in underserved communities?
Sure. I think, again, that goes back to some of the education components and the reach out into the communities and being able to fund our community-based organizations, our faith-based organizations, those that are trusted messengers, and being able to deliver this information. And I certainly anticipate that we're underdiagnosing and under-evaluating the amount of long COVID that are in these communities and communities of color. And that part of that comes from my experience with talking with people and leaders in these communities as we work on some of these long COVID efforts. And what I've heard from some of those individuals is, I haven't been able to concentrate in a really long time. I had COVID and I've been having this problem since then. I haven't been able to concentrate. I've lost my memory, but I don't know what it is. So people don't have words for it. They don't know what they're experiencing. They just know they're suffering. And I think that's why it's really important that we get this information out there and that we funnel it through all of our trusted partnerships, because people are suffering and they don't even know what it's from.
Well, thank you so very much, both Dr. Vanish Krishnan and Dr. Shavinsky. Thank you so very much for your presentations. It's been very valuable, and really, again, appreciate you being here and presenting to us. Thank you. Senator Newman, did you have any concluding remarks before we move to public comment?
Very briefly. So thank you, Mr. Chair. Thank you to everybody who participated in today's hearing, particularly those, very brave, as Senator Lave and others noted, folks who've experienced COVID firsthand. And to the medical professionals who are working so hard on finding solutions and rendering clarity around long COVID. I thank you. This is clearly a project that will go on, and I know I speak for Senator Pan that we are committed to working with you as we do that. Thank you.
Thank you, and I too want to thank all the presenters and especially the patients and families who shared their personal stories. And there certainly is a lot of work before us. With that, I do want to move to public comment. So we're going to first hear public comment from people present in the chamber. Given the limited amount of time we have left, I ask that you need to introduce your name. If you're representing an organization, the name of the organization, and each comment give you 30 seconds. And then we're going to then move on to our phone lines. So we'll begin with the public gallery. See, we're starting over here? Okay. Please begin. Name, organization, if you have an organization, and then set 30 seconds.
My name is Max Bonilla. I am not associated with a specific organization, but I just wanted to say that California has had the lowest COVID infection rates for months, but yet Newsom chose to extend the indoor and school mask mandates. And you say that you care about us young kids and that you want to hear me out, but the policies you've been implementing don't align with that. You say it's an inspiration, or that I'm an inspiration. But in my eyes, the money in your back pocket is inspiring you more than I ever will. Public office shouldn't be a political thing.
Thank you so very much. Next
It should
speaker.
be a...
Next speaker, please. You get 30 seconds is up. We do have a lot of people who want to speak. Thank you. Welcome.
I'm an RN and an FNP. I'm coming today when I saw
Can you please introduce yourself? Name, please.
I'm sorry, you didn't hear me. My name is Genevieve Buckley. I'm a labor and delivery registered nurse and a family nurse practitioner, speaking out greatly against your primary prevention policies for COVID-19. Given that the surge of Omicron has come, the virus will continue to mutate. There will be another variant. There will not be a vaccine that can manage this. And I appreciate your concern, and I really appreciate coming and hearing all of the comment from other people. You're taking an authoritarian position on people's health.
Thank you, ma'am.
This is a democratic
next speaker, please. Please introduce your name first.
My name's Melissa Crew. I'm with the Alliance, a nonpartisan alliance of California. The opening statements and statistics, as well as testimonies that you selected to be heard today, are not without bias. When it comes to COVID narratives in Sacramento, there is no equity. Since we, the public, who are without conflict of interest, are not given the opportunity to present our experts, I'll address the most glaring reason why you are without objectivity and you're not qualified to be the chair of the Health Committee in Senate.
Thank you. Next speaker.
December through
Thank
January.
you. Thank you. Next speaker, please.
Hello, my name is Nikki Myers. I just want to talk about some reckless and dangerous elements that you have to consider. 80% of children ages 5 to 11 have acquired natural immunity. Natural immunity means those children will have high amounts of antigens in their body, potentially for years, and forcing any kind of vaccine or mandate on them after natural antigens present is known to cause hyperimmune response, which is very likely causing death. That is 6 million children in California. That is almost 5 million children at risk for very high death from a vaccination. And
Thank you.
even if you cut that in
and
half,
I would point
that's
out
two.
this hearing is on long COVID, but thank you. Your time is up. Next speaker.
Hello, my name is Kasia Williams. I'm an elementary school librarian. We went back in person October 2020. None were vaccinated against COVID. We made it through the year. Fall 2021, again, same thing. I would like all my children to attend school in person next year, regardless of the vaccination status. The vaccine doesn't stop the spread of the virus. If they can't attend school in person, healthy children are discriminated because they will not be able to attend school and get educated. Thank you.
Thank you. I remind you, this is a hearing on long COVID. Next speaker.
Catherine McBride, Placer County. The number of positive cases at 8.5 million and deaths at 86,000 are highly inflated. The number of cases means number of people who received a positive COVID test. They're highly inaccurate and over-exaggeration of positive tests. Up to 90% of the time, according to Mike Eden, Pfizer's chief science advisor. Deborah Burke says that deaths are counted the same as from COVID as with COVID. Frontline doctors have had tremendous success
Thank you.
with early treatments as
Thank you very much. Next speaker, please. All right, next speaker, please. No, I can hear you.
Very good.
Hi, Dr. Pan. My name is Shrina Lach. I worked in the laboratory field for 20 years. I am currently the lead Sacramento advisor for an organization led by James P. Bradley running for U.S. Senate. Today, I'm speaking on behalf of my experience and knowledge of viruses, side effects of vaccines, and I would like to offer you some facts for consideration that you may not be aware of, or maybe you are, in determining what action you're going to consider in regards to the emergency response plan. To determine long COVID impacts, one would have to have long-term studies.
Thank you. Next speaker.
Dr. Pan, you need to let us.
Thank you. Next speaker. You are free to submit written comments in writing to the committee, which will be part of the record.
Dr. Pan, 1 minute is not enough.
Well, I apologize, but we do have a lot of people. In fact, there's a lot of people speaking here. Next, sorry, you have, the rules have been set. Next speaker, please. Please submit your comments in writing then. Thank you.
My name is Cherish Castañeda. I represent the Hispanic community, the children, the youth, the men and women of Sacramento County, and you do not speak for us. I declare for the record you, Dr. Pan, Thomas Argon, Olivia Casari, shall be held for medical malpractice by we, the people of Sacramento County, the constituents that you do not represent. The corporate interest is what you represent. You and Newsom are guilty of conspiracy with the Communist Republic of China. We will not tolerate your trespass against us. We will hold you accountable.
Thank you. Next speaker. Racism is not accepted here. Thank you. Next speaker.
I am Linda Hardrath, a mother, a grandmother. Current reality, and from the other side of the ship, the CDC states that 36 children died of COVID in the USA, and that is not just in California. It was maybe 5 in California, and that number reduced to 0 by April 2021. After this mandate, 3 million in California are highly likely to die from hyperimmune response from vaccination after having natural immunity testing for natural immunity using
Next speaker,
T-cells.
please. Next speaker, please.
Any child, and we.
Next speaker.
Recall Gavin 2020. Unfortunately, we didn't recall him, but the community we represent feels the fast-tracking bills that you're waiving. The 30-day hold's extremely reckless and dangerous, Dr. Pan, and all of you below. The data is presented cannot be ignored. Claiming deniable that you didn't know better is now gone. We used to have trust in our elected representatives to do necessary critical thinking, necessary to make safe decisions for our community.
Thank you.
We have lost that.
You. Thank you. Again, I would point out this hearing is on long COVID. All right, are there any other speakers at the gallery? So, all right, so we're going to move on to the phone system, please. So let's, moderator, will you please open the lines and call for members of the public who wish to make comment? Again, it's 30 seconds. We do have a hard stop at 3:30, which is unfortunately only, given the time gallery, we only have a couple minutes left, but at least I want to give them at least some people the opportunity to be able to speak. So moderator, if you can please open the lines.
Yes, thank you, Mr. Chair. Ladies and gentlemen, if you wish to provide public comment, please press 1, then 0. First, we will go to line 39.
Okay, welcome.
We the people, you have no right to limit capacity of that room. You have no right to cut the phones. We the people, not I the government. Your game is up, Richard Pan. We are coming for your job because you cannot hide the truth. And the truth is there in the room.
Operator, unfortunately, it's not on the topic of the hearing. Next comment, please. Next speaker.
Next, we will go to line 68.
My name is Trish Munoz. You do not represent all of us, we the people. Vaccines have been proven, per many people's words here, they are not effective. And yes, this does relate to long COVID.
And next, we will go to line 76.
Thank you.
Line 76 has disconnected. Next, we'll go to line 124.
Hello, can you hear me?
Yes,
Yes,
please
we can
introduce
hear
yourself.
me? Okay. My name is Rachel. I'm not affiliated with anybody. First of all, after listening to you speak, you're making correlations and statistical conclusions that don't exist or could have many different factors. You talk about you not knowing the severe and permanent disability or effects of long COVID, but you also don't know that about the vaccines. Nobody does because there's been no long-term studies. What there has been is 30 pages of negative side effects that just got released from Pfizer, not to mention the myocarditis that is so bad in children that Orange County is now having to test children before they play sports. We do not want mandates. This is wrong, and you should not put this on our people. Thank you.
Apologize, unfortunately, we are over time now. It's now 3:31, and unfortunately, we're not able to take additional public comments verbally. However, you can submit public comment to the committee through our website or by email. And so if you wish to submit public comment, please do so for the record. Again, I want to thank all the individuals who participated today. Again, want to thank all of the presenters. You provide us very valuable information that we need as our legislature and the state government needs to figure out how we're going to address the needs of people who have long COVID, how we're going to try to prevent additional cases of COVID that may lead to long COVID, but also ensure that people who have long COVID receive the services that they need. So again, I want to thank everyone for their patience and cooperation. And again, and for anyone who wished to make comment but unfortunately was not able to because of our time limits, your comments and suggestions are important to us, and please, we want to include your testimony in the official hearing records, so please submit them in writing to the Senate Committee on Health. So again, with that, any final remarks, Senator Newman, before I adjourn?
None. Thank you,
Okay.
Senator Pan.
Thank you. Well, again, thank you to all the presenters. Really appreciate you taking out your time. And with that, we have concluded this agenda of this informational hearing on the long haul, preparing for the impacts of long COVID. The hearing of the Senate Committee on Health and the Special Committee on Pandemic Emergency Response is now adjourned. Thank you.